As of now, the World Health Organization has classified monkeypox as moderate risk, with at least 257 confirmed cases across 23 countries, including in Europe and North America. The virus has been considered endemic to parts of Central and Western Africa for decades, with cases rising steadily since the 1970s. But a global spread, even of this limited magnitude, is obviously new. As of this past Tuesday, the U.S. had at least 17 cases in 9 states, the first of which was discovered right here in Boston. So how much of a threat is monkeypox to a population still shaken by COVID? I'm joined by the doctor who made that first diagnosis, Dr. Nesli Basgoz, Associate Chief and Clinical Director of the Infectious Disease Division at Mass General. Doctor, it's a pleasure to meet you.
A pleasure to meet you as well.
You know, the story that Felice Fryer wrote about your diagnosis read like a mystery thriller. You meet the patient on admission at May 12th. Penicillin and antivirals don't work. And it's only after the symptoms appear, rash-like symptoms, that appear, I think, like smallpox, even though it's been eradicated, that all of a sudden this begins to crack open. What happened?
I think part of what we do in patients is to observe the trajectory of their illness, the evolution of their illness. And initially, his rash looked very much like chickenpox to me. Mm-hmm. And we considered that possibility. We considered sexually transmitted infections. It was only really watching him every day for several days in a row that I saw him worsen despite the treatment. And I also saw the rash change over time. At least some of the skin lesions that were quite persistent were changing.
You know, one of the things that I loved about the Globe story and about your experience is the intense collaboration that happened almost in a nanosecond with people locally, statewide, internationally. I spent a lot of time on the show railing about the fact that we've learned nothing from COVID. But one of your colleagues in that Globe story says, were it not for the experience of COVID, the level of, for example, international collaboration at warp speed could never have happened. Do you buy that analysis?
I think it's absolutely true. I think these efforts started long before COVID, the sort of One Health efforts worldwide. But there's no question that COVID accelerated them.
You know, there are a lot of people, you know this better than I, still traumatized, I shouldn't even say still, traumatized by COVID. So they hear the WHO say moderate risk. And what I hear on my radio show is early in January of 2020, that same WHO said that COVID was not a public health risk until it was. What's your assessment of the risk today of monkeypox in our country?
I think that it's likely there will be more patients who are diagnosed with monkeypox. However, I think there's extensive past experience with outbreaks both in Africa, where the disease is endemic, but also in the US. There was an outbreak related to infected prairie dogs from Ghana that were inadvertently imported here. And it resulted in several cases. And it was able to be shut down pretty readily because the kind of close contact required can be prevented.
By the way, there are vaccines from what I understand, are there not?
There are. There are 2 vaccines, one of which is specifically approved for monkeypox, that are safe and effective vaccines.
You know, one of the most painful parts of reading about this story for me is that some of the vaccines and the drugs that are available in Europe and the United States, where there have been no deaths, are not available in the key parts of Africa where the numbers, we can put them up, have been much higher, the number of deaths somewhere in the 60s kind of thing. Is this just another deadly example of health inequities, not within our borders, but around the world?
I think you said that correctly. It is a deadly example of health inequities, particularly in the Congo, where the more virulent or lethal strain circulates. In West Africa, I think the strain that sickened our patient is less severe. But yes, it is an example of health inequity. And we're in the process of learning from their experience, but we're not transferring anything back to them in terms of prevention and treatment.
Do you think that'll change as more of a spotlight is directed on that inequity, that discrepancy, or is it sort of deja vu all over again?
I think there has been progress and there have been changes in certain areas in terms of prevention and treatment with vaccine initiatives and also initiatives to address the circumstances that lead to health inequities.
And I'm sure most of the people watching are aware that in most of the cases that have been diagnosed here, there were reports that the patients were men who had recently had sex with other men, but the WHO went out of its way to say this is, quote, not a gay disease, that no one group is more susceptible, more at risk than any other. Is that true in your estimation?
It is true. There's no group that seems biologically more susceptible to this infection. And it's pretty clear that close contact is required, and close contact includes sexual contact. And in some of these patients, that appears to be the likely mode of transmission. But it is true, nobody is more biologically at risk for this in the current outbreak, as far as we know.
So for the people who are anxious, which is almost everybody I know right now, and I'm betting a lot of the people you see, what do you say to them? What are they looking for? What do they do if they see something that causes them anxiety? What's the advice?
I think the first piece of advice is to communicate with your doctor or your health provider about what you're seeing and whether it's a rash or whether you feel like you have the flu. Talk to your doctor. There's a lot of good information out there now. And there are systems for physicians in the community to communicate with the Massachusetts Department of Public Health and with experts in this area. So I would say that's the first piece of advice. And the second piece of advice is really to remember that there are a lot of infections that circulate in the environment and in animals, including your pet dog and your pet iguana that don't generally make us sick, but can if the circumstances are right. So even though this was clearly a very dramatic example of a zoonosis or an infection that is transmitted from animals to humans, it's not the only example. And in most cases, humans don't sicken.
Before you go, I told you before I know a bunch of people who know you well, who think the world of you, and every one of them said, in addition to how talented and good you are, you're incredibly humble. So this may be a wasted effort on my part. How does it feel when you do solve the mystery, like you did for this patient for the first time in this country? What's the level of satisfaction you feel? And I don't mean just because you're a doctor who cares about your patient. I mean, what's the personal satisfaction like when you break that code?
Oh, it's enormously gratifying to see, the way you think, the way you communicate with patients, and those thousands of hours of contextual experience pay off in a situation like this. And so it's very happy, and it's very happy not just on behalf of myself, but on behalf of the other frontline clinicians who don't always get credit for it. As the stories blow up, sometimes we forget about the people on the front lines, whether they're physicians or doctors or microbiologists. So it is a very good feeling to use clinical reasoning skills.
You said it beautifully. It's a pleasure to meet you. Thanks for your work. Hope to see you again, Doctor.
Thank you so much. Pleasure to be here.